and there's so many different levels here in evaluation and management coding, but we have 4 levels of complexity with medical decision making, and they're straightforward. Then we have low, we have moderate, and we have high. One easy way to kind of get an idea of this is you're straightforward. I mean, you're looking at a very specific type of treatment. So our medical decision making is straightforward. I mean, it doesn't take much more. It's that patient that came in with a splinter, straightforward. We know what we need to do to fix it, right? So our number of diagnoses for straightforward is minimal. The amount of complexity of the data is minimal. The risk of complication of death is minimal. We're minimal when we're talking about straightforward. If we have a low complexity of medical decision making, our number of diagnoses, everything's ultimately limited in this case. We have a limited number of diagnoses and management options. The complexity of our data is limited, and our risk of complication or death is low. Moderate complexity, we're moving up a little bit, now we have multiple. So we have multiple number of diagnoses and management options. We have a moderate amount of information that we have to review, and our risk of complication or death is moderate. High complexity is extensive, and the number of diagnoses, of course, is extensive. The amount of complexity of the data is extensive, and the risk of complication of death is high. So you have a patient that presents that was stung by a bee. Okay? Straightforward medical decision making. Low complexity of a patient that presents that was stung by a bee and is allergic to bees. Okay? Moderate complexity, you have a patient that was stung by multiple bees and is allergic to bees. Everybody see where I'm going with this? I'm kind of going up and up and up. High complexity, you have a patient that was stung by multiple bees, is allergic to bees, and was hit by a bus. Okay, so we've got a much higher level of complexity involved. Management options, of course, are based on the number of diagnoses. They're definitive or differential. Various conditions can be treated in various ways, right? The data reviewed and ordered, of course, the amount of data that has to be reviewed is, of course, going to increase the complexity with the patient's case. Before a physician can actually order a lot of the tests and a lot of, they need the information to be reviewed, they need all of that to come into play beforehand. So, and what they need to order to manage that case is requires more medical decision making. We have our risks, and there's 4 separate levels of risk. We have our minimal risk, we have low risk, we have moderate risk, and we have high risk. And the example that I just gave you with the bee stings, that kind of is showing the different levels of risk as well. Minimal is self-limited. Of course, low is, there's several minimal levels. And then we have moderate, which has more than one chronic illness involved, and 2 or more stable but chronic illnesses. So again, that patient that presented with the bee sting, they're allergic to bees, and now they have diabetes and hypertension, which is being exacerbated. So again, that risk level is higher than someone that's just presenting with just a simple bee sting with no allergy. There is a table on the bottom of page 9 which breaks down the different elements required for the evaluation and management risk levels and for the medical decision making. So again, this is broken down. It's kind of a nice little guide to be able to quick reference when you're looking at these coding cases. review of the key components. We're going to actually take a little cruise through the CPT manual, so we'll take a look at these. The next couple of slides are just reviewing the 4 different levels, so it breaks it down a little bit so that everything, it's kind of right there, rather than having a lot of the examples tied in. So you've got essentially just a review of what we just discussed. Bottom of page 12, we're actually, I'm gonna open up my CPT manual too. The evaluation and management codes are found in the front. They're in the red tab, very front. When you first open up to the evaluation and management codes, you'll see a number of tables. These tables, similar to our tool that we had for CMS, is essentially a quick reference guide to assigning our evaluation and management codes. So if you take a look at, we're going to just take a look at the code 99201. That's the first one. In order for, of course, our place of service, right, which is one of our elements of the M coding, our place of service is, of course, an office or other outpatient service. So this would be for a physician's office, right? Our patient type, we have the 2 types, there's actually 4 types, but our patient type is new in this case. Can everybody see that in the table? So our patient type is new. Our required components for this particular code are 3 out of 3, okay? So again, we have we need 3 out of 3 for our, for this code to be assigned. If you take a look at 99201, the descriptor for 99201, if you take a look at that, we have our 3 components listed. So we need a problem-focused history, a problem-focused examination, and a straightforward medical decision. Can everybody see that? So we need all of those components for the patient to be assigned 99201. Okay? I'm trying to show you how these tools work as far as matching them up. So if you take a look at that 99201, of course, you know, we've got our problem-focused, our straightforward medical decision-making, or in our self-limited or minor presenting problem, the severity, or our risk. So we have all those 3 components. Now if you take a look at 99202, and you take a look at that descriptor in the CPT manual, we are looking at, again, for a new patient, and we require 3 key components. So how would you know that it's going to be a little bit different? How would you know? Use the tables and tell me what's a little bit different about these 2 codes. Expanded, absolutely. Can everybody see that? And remember, we talked about that one term that might throw something off? So now, if you think about it, when we talked about in the lecture, the components that made it and expanded, you'd want to make sure that your little bullets are adding up to meet that requirement. Can everybody see that correlation? So these tables can be extremely helpful. Once you know and you count out your elements, and you take a look at your HPI, how many elements you have for that, and you take a look at all of those little components and break it down, you can use these tables as a guide. Of course, you're not going to code from the tables. This is similar to using the index. You're going to go to the code itself. The one thing about the whole arrangement of the CPT manual is you want to make sure you're in the right setting. It's really important because these tables are great, but the only thing is they change from one table to the next, the type of setting in which the patient received care. In the red at the top is essentially the type of setting. And then, of course, the newer established, you want to make sure that you're in the right table for either a new patient or an established patient. You want to make sure that you can establish whether your patient's new or established as well. In Appendix C of the CPT manual, they have some scenarios that are listed in there that pertain to E&M coding, which can be really helpful. Just keep that in mind. I don't mind that, you know, if you want to check out a few of them, just to get a feel for some of the different scenarios that may come up in medical records, it's a great, great resource.
Appendix C.
Appendix C. All right. So in the very beginning of the CPT manual, in green, we've got our guidelines for evaluation and management services. And essentially, this breaks down, of course, our new and established patient. There's a flow chart that is also on Blackboard that breaks down the new and established patient, kind of like a quick reference guide for that, to break that down. That you can, this is essentially the same flow chart. So you want to make sure, of course, whether or not the patient is a new or an established patient before determining which code to apply. Chief complaint, this breaks down essentially what we had just discussed in the lecture. We've got some different terms and definitions for the counseling services that are provided, family history, the history of present illness, different levels of H&M coding, and of course, in the CPT manual, it breaks down the levels of EM services into 6 different components, which are the history, the examination, medical decision-making, counseling, coordination of care, the nature of the presenting problem, and time. Essentially, those are the 6 that we discussed in lecture. So this gives you a little bit more information. There is some notes about different modifiers that may be appended. Of course, what is modifier 26? Does everyone know that yet? Professional component. That's the professional component. So that's pretty much, you may see a couple that pertain, but there's really not many modifiers that pertain to EM services. Where do we find the modifiers? Appendix A. Okay. So the CPT manual continues to break down our different, the nature of the presenting problem. Again, that is our chief complaint. So it breaks it down. This is where we're going to see our descriptions by the AMA of what each of those separate components are. This breaks down the past history, social history, and then we've got our 14 different organ systems listed here for our review of systems. There we'll go down. Time, essentially a lot of the time is broken down into 15-minute increments. You'll see this for a lot of the ancillary services that are provided. What is an ancillary service? It could be an outside service, but essentially in a healthcare organization, an ancillary service may be something that's performed by a PT, an OT, ST, psychological services, social services, kind of someone coming in to provide something a little bit more than what just the provider is providing. But yeah, a lot of them are outside. A lot of them are. But we learned tonight that most people in a healthcare organization are outside, right? That's why credentialing comes into play. So there are some descriptors in these guidelines about what is considered face-to-face. Telemedicine has become really increasingly. Did you know that no codes for telemedicine actually existed up until just recently? And it's been something that's been kind of into play for quite some time, but they couldn't bill for reimbursement for any type of telemedicine. Talk about beta testing for quite some time, but they were no, CMS wouldn't recognize it. And so now that they're starting to get on board, because I mean, that is, if you think about it, they have the kiosks. Has anybody heard of that? The medical kiosks that they're now having appear out there in industry? It's a kiosk where you go and you enter your issue and you get a response, kind of.
Are they going to put them in the airport too?
I know, exactly. But yeah, they are now creating where you, it's kind of like, 1-800 dial an expert, It's amazing what they're coming out with, or travel tourism. Has anybody heard of travel tourism? You're probably aware of it. I think we talked about it a little bit when we were talking about the surgery for the eyes, laser surgery that's not covered by a lot of insurance. A lot of people will travel to outside of the country to have certain procedures performed. Well, that's happening more and more because so many procedures are or aren't being covered by insurance, or because people are consumers and we're all savvy shoppers, right? That's medical tourism. It's now becoming something, if you're gonna pay for it out of pocket, you might as well save a little money, right? So it's pretty interesting. But yeah, they've just now essentially begun incorporating codes for telemedicine into, because it wasn't face-to-face. They consider face-to-face, there's a huge definition for face-to-face here. And, when it was telemedicine, they couldn't really, that's not face-to-face. So in order for it to constitute as face-to-face, they had to rewrite a lot of the guidelines. And of course, Medicare had to also create codes specific for that. Otherwise, you wouldn't be reimbursed for that.
That's why it took so long. Medicare got
Well, yeah. This is true. It took a while for them to, but I mean, people were actually providing service, and they've been doing it probably since maybe 2007. They've been providing the services. It took quite some time for them to get on board, but hey, they were still, the services were being done for free, and it didn't cost the government anything.
How are they going to, they do the kiosks, how are they going to identify the patient from kiosk to kiosk?
Absolutely, medical record numbers. Each patient would receive a uniquely identifying number. So, and it wouldn't be your social security number, but you would have a unique identifier to be able to. But it kind of makes you wonder, at least for me, is who's the provider that is reviewing my information and providing the care? What are their credentials? What if it's specialty specific? Do they quick shift and the phone call goes to the next provider? Or how does that work? The minute clinics, you see those popping up.
Yeah, like
right?
at pharmacies or something like that. And not say, yeah, kind of like a pharmacy,
Yeah,
but they go in
CVS,
for like,
CVS
yeah,
is doing it now.
they can check you for like, UTI, strep throat, or like a mild sprain, like that, but, I guess what they consider basic
Right.
type things. But if it's anything more than that, then
They refer you, right?
Yeah.
Because I think that at that level, they have like NPs, they have NPs and PAs kind of providing, and maybe even RNs. But, the higher level of that risk level, that's a lot of liability.
Yeah,
And I'm not sure if everybody in here is aware of it, but Rite Aid and CVS are pretty much on the top of the chart on the wall of shame for HIPAA violations.
Oh, really?
Oh, absolutely. So, just as an FYI. So it's kind of, when you see that, we want reliable health care, but we want to make sure that it's being done according to regulation too, right? It's convenient, definitely think it's convenient, you know? I mean, I can't even tell you how many times